Talk a little bit about your wrap up for block three. We talked about uh, all things concerning the knee, knee OA, anterior knee pain, ilio, IT band syndrome. So let's first talk about knee OA. We had some really good discussions on this, um, and some talk about the diagnosis using the Altman criteria. It's an excellent way to go. Um, we really came down to using impairment based physical therapy, meaning we examine each patient independently and treat them based on the impairments that you find. We do know that most are going to respond well to exercise for the quads, for hips, and manual therapy for the same. We also saw that perturbation and agility training was of some benefit in some realms, although the sample size was limited in the Fitzgerald study. Um, what didn't come up a lot this week, and what typically will come up, is, and hopefully it's a dead subject, is arthroscopy or a debridement for patients with knee OA. Really has been shown to be of no benefit for patients with knee OA, so therefore not indicated anymore. And talking about a ligamentous disruption, ACL, it was novel to some that not all ACL tears need surgery. And what patient population would that be to identify that coper versus non-coper? Well, we really have had not a lot of evidence, great evidence to say, well, this is the person that can cope and this is the person who can't cope. There was no association with ligamentous laxity or episodes of giving way for predicting those people who would be able to cope, like you would, uh, think. Um, but those who were fearful of movement, those people tended to have a poor prognosis for coping ability. And then you have to consider activity level of the person, even though all those things there's conflicting evidence for that. So in the diagnosis next up, in what we're talking about, we also talked about anterior knee pain and IT band syndrome. And anytime we use a syndrome, it kind of automatically indicates that there's not going to be a great diagnosis, a great test that's going to diagnose, or cluster of tests often, because there's not really a gold standard that we can compare to. So this, in my mind, elevates the regional interdependence approach using your test retest method. So in the treatment of the knee, we have some evidence for using regional interdependence. So for lumbar, Suter found that a lumbar manipulation increased quad firing, neural dynamics. We talked in several groups was about Lin and Huang, found that there were quite a bit of positive neural dynamic tests, and treatment helped these people with those that were classified with anterior knee pain. Hip, there's quite a bit of evidence for strengthening the hip, and then Courier in 2007 had a clinical prediction rule for those with knee OA that would benefit from a long axis hip distraction. Obviously, we should be treating the knee where the primary issue is. And then there's a little bit of evidence for treating foot ankle impairments. There's a case report about a cuboid whip technique for IT band syndrome, orthotics and treatment of anterior knee pain, and then some activity modification. We have some evidence for changing some of those running mechanics, but certainly using a multimodal approach and not any one of these by themselves would be helpful for treating the knee. And I think this is where most of you said that you were in your treatment. So all right, thanks. HIP is up in block 4, and be sure to post and respond to others on the objective portion of your case example.